Good evening, everyone. A very warm welcome to this joint webinar of the Asia Pacific Glaucoma Society and the International Society of Glaucoma Surgery. I would like to thank Dr. Tarek Shaarawy, President of the International Society of Glaucoma Surgery, and Dr. S.K. Fang, the President-elect of the Asia Pacific Glaucoma Society, for arranging this fabulous webinar. So in this webinar, we'll be covering the entire spectrum of glaucoma surgery. And I would like to thank our sponsors, the Advanced Ophthalmic Innovations, who have supported this webinar. So we have a fabulous faculty with us, Dr. Tarek Shaarawy from Switzerland, Dr. Michael Coote from Australia, Dr. Do Tan from Vietnam, Prin from Thailand, Joseph Anthony Tumbocon from Philippines, Paul Chu from Singapore, and Keith Barton from the UK. So this surgical webinar will cover trabeculectomy and its rescue operations, the malignant glaucoma, and also cover the primary and secondary tube surgery and complications. And finally, we have Keith covering the important aspect of how to choose which MIGS to implant for which patient. And we would like the audience, we already have more than 2000 registrations. So you have the Q&A button. So you can click on the question icon and we'll be recording all the questions. And then after you have all the speakers lecture, we'll have a live Q&A with all the speakers. I would now like to hand over to Dr. S.K. Fang, the President-elect of the Asia Pacific Glaucoma Society, to continue with the webinar. SK, please.
Thank you, Tanuj, and thank you, the members of the ISGS, for joining us today. I would like to just give a short introduction to the Asia Pacific Glaucoma Society. We have formed Asia Pacific Glaucoma Society in 2011, and mainly we are here to promote excellence in diagnosis and care of patients with glaucoma. And we would like to encourage everyone to join our society, mainly because we have benefit from a lot of educational resources, which is listed down here. I will just give a bit of details. We have discounted registration to the APGC, which I will share in a short while. And we have now an online education platform. We have the recordings of all these webinar series that we are doing at the moment, and also a list of surgical videos which are educational. I won't go through the rest of the benefits, just to share with you the email address, our website, and the QR code. So you can scan this QR code and get access to the membership portal of the society. And I would like to also introduce our fully virtual meeting. Due to the pandemic, we are not able to meet face-to-face. So we'll be having a fully virtual meeting from 4th to 8th of June 2021. Do join us for this virtual meeting for this year. And hopefully next year we can meet face-to-face. So without further ado, I would like to introduce Professor Tarek Shaarawy, who is the head of the glaucoma unit in University of Geneva Hospital, Switzerland. And he will be talking to us on how to deal with bad blebs.
Good evening or good morning, wherever you are. It is an honor for me to participate in this symposium. I have, throughout the years, enjoyed a lot of collaboration and very fruitful and rich collaboration with the APGS, and enjoyed lots of friendships in the region. So I've been asked to speak about bleb nightmares, and whenever you try to avoid a bleb nightmare, you have to remember that the raw material for you to do or to construct the bleb is the conjunctiva. So remember to take a good look prior to the operation on the bleb. And as you see here, I don't just look at it, but I also touch it to be able to understand how thin or thick it is. Again, something very simple when you are starting the operation is to do some hydrodissection of the conjunctiva, which will give you immediately an idea, a clear idea about if the conjunctiva is in a good shape or not, if it is scarred, glued somewhere, and if it is going to give you some difficulty as you close it. As you close the conjunctiva, and we all know that, it's very important to make sure that you use a round needle, not a spatulated needle, to avoid tearing the conjunctiva. Always use a forceps that is serrated, as you can see here, what we call the anatomic forceps, and make sure that as you pull on your conjunctiva, that it is fully stretched, absolutely fully stretched on the limbus to be able to give you a watertight space on which the bleb or in which the bleb is going to be formed. As you can see here, it is really, really stretched tightly on the limbus. Now you can meet cases like that where at the end of the operation, you're unable to bring back the conjunctiva in its place. One thing you can do is to try to work on the back end of the L-shaped incision that you have here. I'll just go on and change this to show you that better. So you work on the angle and try to suture forward, which is not always an easy idea to do. Most cases will need in a situation like that, if you are unable to close it tightly, a flap. As you can see here, this is a conjunctival autologous flap that you take, and as you can see, you suture very tightly, tamponating the site of surgery to be able to have a bleb that is forming in a good way. But let's not beat around the bush. The bleb is not a natural thing. Bleb is an insult on the otherwise beautiful topography of your globe. And we always hope to get a bleb like that, not too raised, not too atrophic, not too vascularized and functioning. And unfortunately, this is not always what we get. We get 10 to 15% of our patients that are really suffering from their blebs and absolutely uncomfortable about them. Blebs like these that could be a precursor for blebitis and endophthalmitis and hypotony. Now, blebs that are not comfortable to the patient can be treated or managed with Paul Palmberg sutures. Over the years, I've done many of those, and I've been astonished at how fast they can improve the symptoms of the patient. Actually, you do them one day, the next day the patient feels already much comfortable about them, about the sensation in his eyes. But blebs like those are usually noticed by the patient as disfigurement, and patients do not appreciate something that is encroaching on the cornea like that. This is another bleb that you can see here with actually a lesion of dehiscence or a lesion of a scleral flap that is somehow torn in this area with actually choroid coming out. This is post-deep sclerectomy case with leakage. And the only thing that I know to do about that is to take it out and totally reconstruct it one more time. And a bleb like that, which is absolutely avascular, unfortunately, is a ticking time bomb in the eye of the patient. You can see here a bleb that is associated with severe hypotony. You look at it and you see a little bit of sidle, but then a bleb like that needs to be fully examined. So take your time, look well, because as you move from one part to the other, you see that the filtration coming out of the bleb is much more than you imagined it to be. So you can see here actually a very big amount of leakage. And in a case like that, don't be shy to basically excise a bleb like that. Of course, you run some risk of losing control of intraocular pressure, but anyway, this is a case where there is a hypotony, there is a leakage. The risk for endophthalmitis in a case like that outweighs the risk of excising a bleb like that. If you're lucky, you can pull down the conjunctiva and suture it in its place. And this is the same eye a few months later, a bleb that doesn't look so beautiful, but functions well. Engineer friend of mine, who I enlisted his help in trying to record the bleb. How did that happen? Well, I have a patient of mine who kept actually complaining about the sound of a bleb. So he created this micro studio for the eye to be able to try to listen to what the patient is telling us about. And we recorded a sound that we amplified. And that is what the patient told us, basically, that he hears and is driving him crazy. So I go on and try to run this. Yeah, this is basically what we recorded. So imagine having something like that in your, imagine having a sound like that in your eye that is driving you crazy every time your eye blink. So blebs can be nasty and they can be noisy as well. We can probably get better blebs if we do deep sclerectomies. You can see here a dissection for a deep sclerectomy, and you understand that part of the bleb is actually intrascleral. So those blebs are usually less prominent than a bleb with after trabeculectomy. And a lot of studies have shown basically that those blebs are associated with lower profiled blebs and that are more comfortable to the patient. Well, MIGS is here, and we are hoping one day to have a blebless surgery. Well, the day when the bleb comes, I would actually say good riddance for blebs, but at the time that we have now, we still are at the mercy of blebs in most of our surgeries. True that devices like the pressor flow can provide us with a different sort of blebs, what I call a hybrid bleb. So you can see here the implant, and you can see a bleb that is very far away from the limbus and that is not prominent at all. And I suspect that studies will show in the future that those blebs will be more comfortable than blebs that we see after trabeculectomy. With that, I thank you very much. In the last 10 minutes, I tried very hard to give you all what I can give in 10 minutes about blebs. Thank you very much for having me, and it was a pleasure. Thank you.
Thank you, Tarek, for that fabulous presentation on how to deal with bad blebs. And our next presenter will be Professor Michael Coote from University of Melbourne. And Michael is one of the masters of trabeculectomy surgery, and he is one of the innovators of how to revise a trabeculectomy once it has failed. So I'd like to invite Michael Coote to give his lecture on revision trabeculectomy.
Well, welcome, and it's lovely to speak to you, at least virtually. I'm in Melbourne, Australia, but it's disappointing not to be able to travel. As usual, thank you very much to the organisers who've had a particularly tough gig, I think, trying to get things together in these circumstances. And hopefully we're looking at things that are getting better over time, not for a little while, I suspect. I do have some disclosures, although none that are appropriate for this talk. I do work, obviously, at the Royal Victorian Eye and Ear Hospital in Melbourne, as well as the Centre for Eye Research, and a lot of people contribute to what we do in all areas. This is the Eye and Ear Hospital in Melbourne. It's gradually getting a renovation, so hopefully the next picture I show you will look a bit more modern, but it sits in a plum position. The topic I've been given is really a huge topic, because many, in fact, probably most glaucoma operations at some point are going to need revision. In fact, the data suggests that about a third of them will fail and need operation, some form of reoperation within 5 years. Now, often we resort to needling, but it's not all that effective, and most of us who've done a fair bit of it over the years recognise that the data that I'm presenting is pretty right. About 2/3 were effective at 6 months, but really only about 20% at 2 years. Now, it's a bit better if we use mitomycin C, but it's still fairly poor. Revision is also used when blebs are not working, they're leaking, they're dysesthetic, uncomfortable, over-draining or encircling. So they've got a lot of other aspects as well as just not functioning. But the most common purpose that we'll employ a reoperation for is a failure to filter. And that's a rich pantheon of blebs that haven't worked. So I'm sure you have plenty in your own practice. So the formal title of what we're talking about is a revision of trabeculectomy. But of course, anatomically, we're not really doing a revision of trabeculectomy all the time. We might also be revising the ostomy, or the hole, the flap, or the bleb itself, and maybe all three. The most common reason for failure of a glaucoma operation, certainly with high pressure, is in the subconjunctival space. So mostly we're going to be revising blebs. Blebs, of course, are aberrations that are created by surgeons and are supported by chemotherapy. Now, I'm going to run through a couple of forms of revision. This is the first one, which is a somewhat classic revision. We're starting at the posterior area, mainly because moving through a bleb, starting limbally and going through a bleb, is a technically quite difficult process. This way, we are in relatively normal tissue and move through areas of scar. And you can see there's quite a pronounced episcleral collection here. We do need to be fairly fastidious about hemostasis, but you can see that the sclera itself is actually relatively clean. You can pull off this episcleral tissue, and then you reach the area of adhesion, you reach the area of impervious scar. At this stage, what I'm doing is going over the top of the flap, and then we're going to delineate the flap itself. Now, you'll also notice that this is not the whole of the flap, but really just one half. All of this has to be done before we put mitomycin on. Unfortunately, mitomycin does need to go over the corner of the flap in order to keep it open. And so we do need positive pressure in the eye when we're doing this. So at this stage, I'm going to fill the eye with viscoelastic now, fairly firm fill, so there's a positive pressure. It also proves, of course, that we have plenty of access into the anterior chamber. We need to make sure that there isn't structures that allow this bleb to refail. Of course, we need also fluid to go somewhere, so we need to remove the bands posteriorly and make sure that when we're putting mitomycin C, we're actually making enough chemotherapeutic bed for the operation to work. Diathermy is a great contributor to the effectiveness of mitomycin. This is a 0.4 milligrams of mitomycin C on a PVC sponge. And it gives a kind of limited amount of it, but also a relatively stiff object so that you can tell broadly where it goes. I've shown the sort of difficulty of squeezing it in, but it is important to understand that you do need it to spread over it, and it also needs really to come up firmly against that posterior lip of the flap. In general, this is an eye that is full of viscoelastic, so it's particularly important that there is still positive pressure in this. We don't want it to leach out. And of course, we're not meant to leave anything in the eye that can't get out easily. So if we're going to leave viscoelastic in the eye, we need to prove at the end of the process that there is enough of a sclerostomy for it to leave easily. Atovicral on a blood vessel needle is a great way to close conjunctiva. You can do it in multiple layers if you wish to, but I think single layer for posterior closure is quite adequate. You can use an over suture, or you can use a purse string suture, but it's best also just to make sure that there is complete closure here. It's less important than at the limbus, and it's usually technically, in some senses, a little bit easier, although access is still a problem. These really do need local anaesthetic, and we do need to get full akinesis of the muscle so that we can pull it down. When we put viscoelastic in the eye, as I say, we have to allow it to get out, so there does need to be a pressure test. You can see that there's now a bleb and it's gradually increasing. Also very keen on higher doses of steroids. If you do have to resect a bleb, you will have a limbal incision. And one of the most important things you do then is put some subconjunctival triamcinolone in order to make sure that there isn't contraction and retraction of the wound. Now, this is a variation of this. It's called, somewhat cleverly, minimally invasive revision glaucoma surgery. The attempt here, though, is to give a kind of more minimalistic crossover between perhaps a needling and a formal revision. Now, this fellow had an axial length of 36, very late stage disease, He had a non-penetrating operation around 5 years before, which kind of gradually failed. And you can still see the effects of mito there. You can see that his sclera is really coming out quite white, and he's got an intermuscular septum, as everyone does, and you can go behind it. But you can also see that there's a large flap that's fairly, or at least cap, that is fairly thick. He's reasonably vascularized, but it's a diffuse cap, and to needle this would be unlikely to give you anything other than very temporary relief. When we're doing these sorts of revisions, we often will use both sides, and I'll show the other side in a second. But again, you are still using chemotherapy to create blebs, so the application of mitomycin, where it is, exactly how far it goes into the bleb, is critical to the success. Non-penetrating surgery has different failure patterns. Broadly, most of it is in the subconjunctival space. Sometimes, if you're unlucky, the flap itself, because it is larger, can stick down. And of course, early on, you can get blockage of the non-penetrating membrane, and that can require a goniopuncture. That isn't part of this, and this man has already had a goniopuncture. If he had not had a goniopuncture, you'd certainly want to do that. This requires there to be an intact ostomy, and the flap itself is not adherent. And you can see that he has a bleb over the top of the flap. So we're really now just doing a bleb revision as opposed to an ostomy or a flap revision. Blood is a compelling way to stop mitomycin working. Mitomycin will absorb blood. So if you are putting in sponges that are getting covered in blood, you may well need to replace them. Mitomycin adheres to protein quite rapidly, and as blood has a fair bit of protein in it, you can end up with something that really defeats your role. We do now use a sharp blade to incise the side of the bleb. You can use an MBR blade, you could even use potentially a needle, but we're doing this more or less under direct guidance. And what we're doing is making a large incision. If you are doing this to the plate of a tube implant, it's more valuable at that stage to actually cut a window out of it. That's not strictly possible here, but it's important to get good access into the bleb and make sure that there is reasonable flow into that area now that you've created with the mitomycin. But you'll notice that at this stage, we're not really going into anything other than just the bleb. We're not now entering the anterior chamber. The track with a non-penetrating operation is substantially longer and more difficult to navigate. So in this instance, we still have enough of a barrier. You can see that we're getting in to really flattening that bleb off. You could add a little more mitomycin if you felt that you hadn't got adequate, but the mitomycin really does need to be over that area of opening. They can be closed quite gently and with minimal involvement. And he's going to have, and did have, a nice post-operative course, and in fact remained with functioning bleb and vision until he expired around 2.5 years after this operation. Thank you, everyone. I hope that you stay well in these difficult times. Glaucoma operations often are, they're an operation for life. We do need to make sure that our patients' eyes are supported by functioning operations. If they're not working, they need revision. And the next step after revision is not always a glaucoma drainage device. Sometimes we just need to re-revise. It is also subconjunctival, not intraocular, so it can be done again. Many thanks. Enjoy the meeting. All the best. Bye-bye.
Well, I would like to thank Michael for excellent talk on the revision of trabeculectomy. Going on further now, I would like to introduce my good friend, Dr. Do Tan, who is in Vietnam National Institute of Ophthalmology. He will be talking to us on surgical management of malignant glaucoma.
So hello everyone, I'm Dr. Do Tan from Vietnam National Eye Hospital. First of all, I would like to say thanks to the organizing team for inviting me to be a part of the very important and interesting symposium on glaucoma surgery. So my topic I'd like to cover today is surgical management of malignant glaucoma. Malignant glaucoma, firstly described by Wolfram a long time ago, characterized by the shallow or flat anterior chamber with a high intraocular pressure, usually after the intraocular intervention, with acute onset and very visually devastating. For this clinical entity, the medical management is very high rate of failure, and surgical intervention is normally very challenging. In terms of epidemiology, it normally counted for 2 to 4% after the filtering surgery for primary angle closure glaucoma. So in terms of mechanism, there are many hypotheses, and in general, with the predisposing condition such as primary angle closure glaucoma, short eye, and big lens, with the sudden change in IOP during the surgery, leading to the valve-like effect and posteriorly misdirect aqueous humor, and after that, pushing lens iris down forward. So that's why now literature came out with a newer and better nomenclature, aqueous misdirection syndrome. Sometimes we need to differentiate with several diagnoses. For example, the acute primary angle closure glaucoma attack or suprachoroidal hemorrhage or choroidal detachment, where the imaging method would be very important. So in terms of management, we have several choices. Normally, we will start with medical treatment with psychoplegics, IOP lowering, hyperosmotic agent, and of course with hydrosteroid. If the medical treatment fails, you can move to the laser treatment. You can laser anterior hyaloid or laser ciliary body. And most of the case, we end up with surgical treatment. So for the surgical involvement, we have several moving forward along the history. Firstly, Schefter in 1954 described a technique including spiral incision and vitreous aspiration, but he admitted that with high rate of recurrence, and of course with high risk of complications such as hemorrhage, retinal detachment, or choroidal detachment. And after that, the other authors described more advanced techniques, including lens removal and vitrectomy. So lens removal and vitrectomy is the ultimate purpose is to create the communicating pathway that can be lens removal plus posterior capsule opening with success rate up to 100%. But for this kind of technique, we still have the risk of synechia between the posterior capsule and intraocular lens, and that can create the recurrence. So another way is to make the pathway by lens removal and hydrogelulectomy with very good success rate, with other advantages over the previous technique. So with this technique, we can solve the weak point of posterior capsule opening and we can decrease the risk of recurrence. So why in Vietnam we do the endoscopy assisted vitrectomy? Because normally we around the world we can do vitrectomy with the open the wide angle system, but with endoscopy assisted vitrectomy you can have better visualization through the corneal edema, through the non-dilated pupil, that very common size, common problems in the malignant glaucoma eyes. Also, with endoscopy, you can get better access to far peripheral vitreous space and to preserve the posterior capsule easily, and also for the surgeon to easier to photocoagulate the ciliary processes if needed to control the IOP after the manipulation. So now I'd like to share with you my technique that endoscopy assisted for malignant glaucoma. So that's the case where a 60 years old woman operated for trabeculectomy 3 months ago. And 2 weeks after he got the malignant glaucoma, and that responded partially with oral aqueous suppression. Whenever we stopped the oral treatment, the anterior chamber got shallow again. So finally, the surgical intervention were finally indicated, including lens removal, IOL implantation, and of course endoscopy-assisted anterior vitrectomy, and halojonular capsuloidectomy to restore the AC depth. So as you can see, we have 3 steps of intervention. Step 1 to do the core vitrectomy, step 2 to do the phaco in normal manner, and step 3 to do the vitrectomy and also the ilectomy surgically. And first of all, we will put inside the infusion line and do the sclerotomy superiorly. For this case, it was done a long time ago when we still use the 20 gauge system, and so that's why we do the sclerotomy with 20 gauge knife. But now it's even quicker with the 23 gauge system, and with, of course, with 20 gauge system endoscopy. So as you can see, we are doing it's called vitrectomy to soften the eye and to help you the phaco surgery had more room to manipulate, because you know that the anterior chamber is very shallow. So when the eye is softened like this, and we will do the phaco mastication in a nearly normal manner, and do the side port main incision, do the capsulorhexis, and remove the lens, and do the eye aspiration and put the implant in. And after that, we will switch to the anterior vitrectomy. You can see that with the help from endoscopy, we will see very clearly the vitreous space. You see nicely the infusion line, and you see nicely the ciliary processes. And we've done the anterior vitrectomy nicely with the help from endoscopy. And after that, when we finish the anterior vitrectomy and we do the very important part of the surgery is to do the halojonular ildectomy with a vitreous cutter from behind. And that's why we can make sure that we will create the very patent communication between the anterior chamber and posterior chamber. And that's why we can balance the pressure ingredient throughout the iris diaphragm. And that's why you can make sure that nothing blocks the pathway, and we will 100% sure that posterior you can restore the anterior chamber. So the surgery is done, and let me show you the image post of 3 days. And see that very nice reform of anterior chamber, and very good result of also the intraocular pressure. So our series now, let me show you some result of the result on 53 eyes of malignant glaucoma that indicated for vitrectomy to restore the anterior chamber and so to control the IOP. And both eyes were failed after the medical and laser treatment. In terms of Thai surgery, for 39 eyes, we did vitrectomy plus phaco and halojonular ildectomy, because this eye got the malignant glaucoma after trabeculectomy. And the other 49, we did only vitrectomy with halojonular ildectomy because malignant glaucoma happened after the phaco trabeculectomy. So in total, we got 53 eyes. So in terms of the visual function, we got after 1 year of follow-up, we got pretty good vision function. You can see that the bar on the right-hand side, we got a pretty good percentage of the good recovery in the visual function. And also very good percentage, up to 95%, the patient got some improvement of visual acuity after 1 year follow-up. Another good result outcome of this series, the IOP result, and we got up to 93% of patients got the IOP under the control after the 1 year follow-up, and with the mean IOP around 70 millimeter mercury. Of course, we have some cases we need some additional IOP lowering agent, and you can see that on the table. Up to 35% of the eyes, 19 eyes needs additional IOP lowering medication. And we have 3 cases we need some additional procedure. 1 case needed trabeculectomy, and another case needed cyclodiode for NVG. We didn't consider this case as a failure because of the problem, the coinciding problem in this patient. That patient got the NVG after the old CIVO, so that we didn't consider that case as a failure. So in terms of anatomy result, we have excellent outcome. We got 100% of cases got anterior chamber reform after the surgery. So you can see that on the right of the table. After 12 months of follow-up, we got very good anterior chamber depth. In terms of complication, we got, as expected, some cases, 20 cases of anterior uveitis after surgery. And the pathway was occluded by the exudative membrane in 4 eyes, and that caused the recurrent flap of the anterior chamber, increase of IOP, but that managed easily. You know, 1 eye we did the additional anterior chamber washout, and 3 eye we did the laser to reopen the pathway, and of course we associate the treatment with the hydrosteroid, and all 4 cases were anterior chamber was reformed. So in terms of final success, though 33 eyes got the complete success that defined a good anterior chamber, good visual acuity, and IOP under control in 64%. We got also relative success defined as the good anterior chamber, good visual acuity, but IOP need some additional medication in the other 33%. And we got only 1 case of failure that I needed trabeculectomy finally to control the IOP. So in conclusion, endoscopy assisted vitrectomy with lens removal is very good method, very good surgical method for malignant glaucoma. In our hand, we treated successfully for 33 eyes. After 1 year follow-up, we got 95% with better visual acuity, 100% of anterior chamber reform, good IOP control, and no serious complication. And the final success is we accumulate complete and relative. We achieved 97%. So many thanks for the attention.
Thank you, Dotan. That was an excellent lecture in a very difficult situation which you managed very well of malignant glaucoma. And now we have Professor Prin from Thailand, who is the president of the Asia Pacific Glaucoma Society, the past president, and he'll be covering how to manage controlled hypotony for long-term success in filtering surgery. Professor Prin, please.
Hello, I'm going to share with you on control hypotony for long-term success in filtering surgery. I'm Prin Rojanapongpun from Bangkok, Thailand. For this presentation, I have no financial interest to disclose. Let's start off with the term hypotony. As we all know, hypotony is when the pressure in the eye is getting lower than 6 millimeters of mercury and with reduced vision of more than 2 lines. But I like to introduce the other term called controlled hypotony, which is just temporary pressure drop and then temporary visual loss for more than 2 lines. This is a bleb in the eye which has hypotony, but the anterior chamber is maintained without permanent visual loss. Quite a nice diffuse bleb to the back of the eye. When we look at the anterior chambers, the AC is well formed. So this is a patient of a male 73 years old of mine, and this is his post-op course. You can see on day 2, the pressure is quite low until 5 weeks, that in the range of hypotony. But when we follow this person to 2 months, 3 months, 1 year, and up to 5 years plus, then you see that the pressure is well controlled in a low range and the vision remains stable. Let me blow this up for you. In day 2, week 2, and 5 weeks, you see pressure of 3, 5, 4, and then just at about month 1, that pressure is fluctuating in the low range of 7 and 6. And when we follow this patient for a longer term, then we see that we can maintain the vision and also the pressure at a low level. But this patient went through hypotony. So is hypotony a problem? Based on the consensus of World Glaucoma Association, low IOP itself is not necessarily considered as complication or failure if it does not lead to permanent visual loss like maculopathies or choroidal effusion. We all understand that filtering surgery is connecting the aqueous to the subconjunctival space by creating a fistula. And we hope that this aqueous go to the bleb that will be taken up by the venous or the lymphatic system and give us a nice diffuse bleb on the right-hand side. So we can connect aqueous to various techniques. The bottom right is the trabeculectomy, the conventional that we do iridectomy and also sclerectomies and then try to connect. The problem is that is you don't always have control lumen size and control tissue healing, whether it's sclerosis. We can also connect that by using shunt that have standardized lumen and also very controlled fashion, and it's always patent, or even with using MIGS that connect with the gel stent, like stent gel stent. So there are various ways that we connect aqueous. And this is a diagram of a perfect filtering. We can connect aqueous to subconjunctival space and hope that as a surgeon, we can do a good connection and always patent. We need healthier conjunctiva to begin with, and we need a good scar control. And then hopefully the aqueous will connect to venous system or the lymphatic system. But in real life, we have inflammatory conjunctiva episclera. Patient has been on several medications for several years. We have no good way or reliable way to control the scar formation, and we fail to connect the aqueous to the subconjunctival space. We fail to connect to the lymphatic and venous system and end up by having a scar bleb that does not function. So failed filtering bleb is common in Asians and Africans, where Asian has propensity of scarring. There are excessive fibroblast reactions and also collagen deposition at wound healing has been known by our plastic surgeon, and as well is applied on the filtering surgery in glaucoma. The key to a perfect filtering surgery, when we analyze that, is if we're able to control the aqueous flow and also the wound healing. Let's discuss on the aqueous flow. For aqueous flow, if we either high flow or low flow, and high flow, we know that it leads to hypotony. Low flow, it leads to failure and close off of the drain. So if we have some way to have a control flow and also control hypotony that is not too low or too high, but just maintain the eye integrity that's good enough to maintain the vision. Talking about control flow, I think we need standardized lumen, we need flow restriction, we need and the shunt or the fistula must be always patent. For the control hypotony, we need something that get the pressure to low level but never lost the anterior chamber, no maculopathy, and less post-op intervention if possible. Now, when we look at wound healing, we know this is a mother nature, so the wound will heal. It's a dynamic process. It's variable or aggressive. It depends on different individuals, and it leading to long-term failure. And right now, we're still not able to win this game all the time. We have been spending a lot of time in adjusting the wound tension, the scleral flap tension at the surgery. But, it's a dynamic process. So all those adjustments need to be readjust again. So it's quite variable. There's a good strategy of using anti-scarring, anti-fibrotic agent like MMC. It has been shown that Asian bleb fails more, and MMC is beneficial. This has been well documented. But MMC or mitomycin C can also create bleb like this, ischemic bleb, the anterior bleb, and then that could lead to long-term complications like blebitis and even endophthalmitis. So to improve the outcome of filtering surgery, I think we need to look at the controlled continuous flow, the standardized lumen that always patent and have a, some kind of control, overcome the wound healing, both short-term and also we need some kind of short-term over drainage because scar formation will take up and then it will reduce the drain in the long term. So we probably need a big area. When I look at things that we need, I think there are several things that we need to look at in this slide, which I'm going to show you in my surgery video. So what I'm sharing with you is a system that we need to create a control hypotony, just like the old days that they do the full thickness filtering surgery to overcome wound healing, but and achieve the long-term success, but also have less complication like flat AC. This is a surgery that taking the idea of combining several things. So instead of packing the mitomycin C sponge in a small area and leading to ischemic bleb, I modify the surgery based on the concept that we need a wider area of packing of the mitomycin C to manipulate the wound healings, to control the scar formation and to control the fibroblastic reaction. But this has to be tailor-made, depends on the individuals, depends on the inflammatory status of the episcleral tissue, the conjunctival health. But you see that I'm packing several sponge. This is a monocell which is tough enough that will not break in between, and then just go to, you have to count the number of pieces and the length has to be fixed. And, we can use different concentration, but you have to work on your concentration. For me, it's a 0.3 milligram per ml, and I pack for 3.5 minutes. And then we'll remove all the sponges, rinse off with the balance of solution. And instead of creating a small flap, this system making a big flap. The big flap is, is trying to get the aqueous to the back of the eye, having more area that aqueous can reach to the subconjunctival space. If certain side of the drain being closed off by scar formation, the aqueous can also reach out to the available connection to the venous or lymphatic system. So this is creating a flap using a crescent knife and then just do more or less the half thickness. Creating a big flap is actually quite easy, quite simple. Dissect the half thickness sclera and then just lift off the scleral flap. So this is the flap that we make. Instead of doing a standard trabeculectomy, a sclerectomy and iridectomy, I have been stopped doing that. And then with this system, we introduce any kind of shunt. It does not necessarily to be this expression. I think we need some flow control that is consistent, always patent, and have a standardized lumen after we have explored this, and then we know that how much in control. The lumen, the external lumen itself, touched off by the root of scleral flap. So if you notice that I do not dissect the scleral flap to the limbus, we leave the two sides so that scleral flap can be closed off. I either apply one releasable stitch or no stitch at all, so the aqueous can drain and then have a flap as a control. And there are several things that we haven't discussed about the lead mechanisms and other things that will keep the bleb ongoing. This will offer a control hypotony that control over them in the beginning, and then we have a big series of this control hypotony for long-term success and produce a bleb that driven the bleb from the anterior bleb to the posterior bleb location. You see that it used to be like bleb here. Now the bleb is going there, so the ballooning is go up there. So we drive the bleb to the back, leave the conjunctiva as a healthy filtering reservoir for the aqueous. In summary, the control hypotony as a strategy to achieve long-term success. If we have a control one, there are complications that we have not discussed with this talk, but I just want to introduce concept. Most of the complications relatively small and can be resolved or can be correct. Use of device, a shunt with a control control short-term overdrainage and hypotony while application of mitomycin C or any other agent, surgical technique modification, intensive post-op intervention, including ocular massage, will further improve the outcome. Thank you for your attention.
Thank you, Prin, for the great techniques on controlled hypotony. Right now, I would like to introduce another great surgeon, Joseph Anthony Tumbocon from St. Luke's Medical Center in Philippines. He will be talking to us in tubes in tight places. Tony?
I would like to thank the Asia Pacific Glaucoma Society and the International Society of Glaucoma Surgery for inviting me to give a talk in this webinar. The AMED, Barbell, or similar types of implants are robust devices that are usually indicated in eyes that have a higher risk for failure for other types of glaucoma surgery. However, there are situations where implanting these devices may be difficult, such as in eyes with a pre-existing inserting band, or eyes with peripheral anterior synechiae, or flat anterior chambers. This first case is an eye that previously underwent pars plana vitrectomy with silicone oil and placement of a 360-degree inserting band. The key concept here is to dissect through the capsule of the inserting band and not over it. Use this as a plane for dissection, going laterally all the way to the recti muscles, making sure that all adhesions to the inserting band is gone. Then as you go through the posterior capsule, the posterior wall of the capsule, you have a large space where you could place the plate of your implant. In this case, we use a fairly large implant, a Barbell 350, and we were able to tuck in the lateral aspect of the implant, the plate, underneath the recti muscles with minimal difficulty. For fixation, you could drive the needle of the nylon suture through the inserting band and out the fixation hole of the plate. This will work as long as the inserting band is still quite snug. Another option is to drive the needle through the sclera and inserting band and out the fixation hole. This will add more stability. Then you complete the procedure as a conventional manner. With proper dissection, you could close the conjunctiva with minimal tension, even though there's two devices at the equatorial region. Inserting a tube in eyes with peripheral anterior synechiae, it could be a bit tricky because the ideal internal entry of the tube should be at the trabecular meshwork. If you have peripheral anterior synechiae, there's a chance that you could snag the iris as you insert the tube. Just like what happened in this case. This eye was receiving a second implant inferior-temporally, and as I was inserting the tube, I couldn't see the tip of the tube going into the anterior chamber and realized that it was going posterior to the iris. So in this case, a useful but simple maneuver is to inflate the eye with OVD, or ophthalmic viscoelastic device, to push back the iris. Then the tube should go in with minimal difficulty. This is the post-op photo. If you focus on the right side of your screen, you could see that the tube went through the peripheral anterior synechiae, but still entered at the level of the trabecular meshwork. However, the tip of the tube does not touch the iris. Again, this technique only works if there's no posterior pushing mechanism. Another option is to do synechialysis, preferably under gonioscopic guidance. This next case is a patient with iris bombay due to occlusio pupillae in a patient with VKH. In this patient, we did a laser iridotomy to flatten the iris bombay, but the IUP remained elevated because of the extensive peripheral anterior synechiae. We inserted a tube superior-temporally, similar to the previous video. In eyes with high peripheral anterior synechiae, such as in patients with eye syndrome, it's sometimes difficult to insert the tube since there's proliferating endothelial cells and tissue that crosses over the angle and spreads through the iris and later contracts. And this leads to high peripheral anterior synechiae. And if you insert the tube into the anterior chamber, there's a possibility that the tube can get obstructed by the tissue and the cell and the iris. So in severe cases of eye syndrome, I prefer to do a peripheral iridectomy since this removes the scaffold for the proliferating endothelial cells and tissue. If the eye is pseudophakic, I insert the tube through the ciliary sulcus and right at the area of the iridectomy. This will decrease the chance of the tube getting obstructed in the long term. And this is the same eye 9 years after AMID implantation, AMID implant surgery. And you could see that the tube is still quite patent, even if the eye syndrome seems to be progressing. This can also be done in phakic eyes, but the entry should be at the level of the trabecular meshwork, and the trajectory is just at the iris plane. You need to be more anterior than the previous case because you don't want the tube hitting the lens. This next case is a patient with epithelial and fibrous downgrowth post-complicated cataract surgery with ACIOL. In this eye, we did explantation of the ACIOL, placed a sclerofixated lens, and then did penetrating keratoplasty and inserted the tube through the ciliary sulcus and with the tip of a tube peeking at the edge of the pupil. These are other examples of sulcus inserted tubes. I still prefer the tube to be visible when the pupil is dilated, since if there's a tissue or a vitreous that obstructs it, you could relieve the obstruction by just doing YAG laser. If there's a pre-existing iridectomy site, you could place the tip of the tube right at the iridectomy site. This will allow good visualization post-op and to monitor the tube for any obstruction. Of course, there's always the option of doing pars plana insertion of the tube after a thorough vitrectomy all the way up to the vitreous base. Similarly, I'd like to see the tip of the tube once the pupil is dilated so that I could relieve any obstruction should any occur. This is my last case. This is a pseudophakic eye with a grade 3 flat anterior chamber and a slit pupil. It is further described by the illustration on the right hand of your screen. And the original plan was to do vitreous tap, reformation of the anterior chamber, and pars plana vitrectomy. But as we tried to reform the anterior chamber with OVD, we couldn't do so since there was high pressure in the vitreous cavity. We decided to do an anterior approach, which has been described by other investigators, wherein you do a stab incision through the cornea, through the iris, through the anterior and posterior capsule, and up to the anterior hyaloid face. And you could see that there's fluid egressing out through the tract that was created. At this point, we could now peel off the iris from the corneal endothelium using OVD. However, there was still residual peripheral anterior synechiae, almost 360 degrees, even if we did this. After which we did pupilloplasty, then did peripheral iridectomy, and then inserted the vitrectomy probe behind the iris to enlarge the pupil further. And then inserted the vitrectomy probe behind the IOL to do core vitrectomy and posterior capsulectomy, also limited zonulectomy. And then we inserted the tube through the ciliary sulcus with the tip visible at the iridectomy site. So this improved the vision and controlled the IOP, and there was no recurrence of the aqueous misdirection for a follow-up of around 2 years. So in summary, in eyes with a pre-existing encircling band, you need to unroof its capsule and dissect along the surgical plane that is created. With eyes with peripheral anterior synechiae, you could do synechiolisis and insert the tube through the PAS, but make sure that there's no posterior pushing mechanism present. In eyes with flat or shallow anterior chamber, you need to correct any reversible cause of this condition, such as pupillary block. You may utilize peripheral iridectomy to create more space in the anterior chamber, or to visualize the tip of the tube post-op, or improve the access of the aqueous to the tube. You may consider inserting the tube through the ciliary sulcus, through the pars plana, in eyes that that's difficult to put the tube in the anterior chamber. Thank you very much for your attention. If you want to view more educational materials, visit our the APGS website through this address. Thank you very much for your attention.
Thank you, Tony, for this fascinating lecture on how to put tubes in difficult and tight places. And our next speaker is Professor Paul Chew, who is from the National University of Singapore and a senior consultant, Department of Ophthalmology, NUH. And he's a great innovator, and he has put forth the new glaucoma implant. So we look forward to hearing from him about the new glaucoma drainage device. Paul, please.
Good evening, and thank you for your attention and giving me the chance to talk about the Paul glaucoma implant. I have the disclosure that I have a relationship to the company that makes it, since I am the inventor of the implant. I'd like to talk about some specifics of the implant and then give some data about how this implant's been performing so far in clinical trials. As you know, trabeculectomy has been decreasing and tube use has been increasing over the years, and that the reason for trabeculectomy decrease is, amongst other things, that there's a higher rate of reoperation for trabeculectomy and also usually a higher rate of failure. When we look at current day tube implants, we notice that there are some problems in that cumulative failure at 5 years is 49% in the AHMED group and 37% in the Barbell group. And this was for the pooled data for the AVP study and the ABC study. However, high intraocular pressure was the most common reason for failure in both groups. And in addition, if you look at hypotony, which occurs in the Barbell group, even the Barbell is having a 40% suboptimal outcome. So therefore, current day tubes, which are necessary for severe disease, still do not really give you very good outcomes, with almost half failing by a year. Can we do a better design? And this has to do with making sure that we have a better plate size, better plate shape, a better tube caliber, and whether a valve is really necessary. So here we go into a new design that we've started recently, and this was developed a few years ago at the National University of Singapore by myself and my team. It has a surface area of 342 square millimeters. It's got a low profile plate design and a soft silicon material that's medical grade. The implant itself has a maximum thickness of about 1.2 millimeters at the thickest, and the surface area is very similar to the Barbell 350. The implant itself sits, as you know, as most of these implants do, under the conjunctiva on the sclera behind the equator, with the tube going into the anterior chamber. And the big advantages we feel are not just adequate surface area compared to the AHMED, but also that there is a small enough tube which doesn't erode as readily, and having a small internal diameter of about 127 microns controls the flow rate to some extent and helps to prevent hypotony. A smaller tube, therefore, having less erosion and more flow control. If these black lines represent the rectus muscles, you can see that the plate, a lot of the plate surface here is not really covered by the muscle. And so if you take away the area covered by the muscle, we still have about 300 square millimeters available. And this seems to be more than what is available for other implants on the market. The internal diameter of the tubing is very similar, and it's in the same area, it's in the same range as the original first generation iStent. Gives you a sense of how big the tube is. And here you can compare the two. You can see that there's a difference in visible size between the standard AHMED tube and the current new PGI device. The ball implant is quite far away from the corneal endothelium compared to the larger Ahmed valve size, and therefore we hope that over time we can show that the endothelium is doing better after implantation with less endothelial cell loss. Here's a intrasurgical OCT showing the tube is flush with the top of the sclera when we cut a little trough, whereas when you cut the same trough and you put an Ahmed tube, it does stick up above the scleral surface, and this may be also a reason why it contributes to erosion of the conjunctiva postop. Here's a typical bleb. With the plate being quite large and low, we get a diffuse bleb without very much of the sharply defined, proud, high edges that you see, which is typical after an Ahmed implant, where you have very steep and sudden rise on the bleb over the plate. And this is all part of the design requirement that we wanted to make sure that we get a good diffuse bleb with good pressure. How's the results been? Well, here's the multi-center trial that we did on the first case series. And the outcomes are that at 1 year, we had 4 failures. About 69% were complete successes, and 93% were considered qualified successes. So I mean, this is quite a high level of success in the treatment group. Here is the pressure lowering results at 1 year, 12 months, and you can see that the range of pressures usually below 15 throughout the 1 year that we followed them up. And if you compare this to the pressure lowering of the Ahmed and the barbell in the ABC trial, the IOP achieved at 1 year is very similar for the barbell and the PGI, somewhere in below 15, and for the Ahmed just slightly above that. Medication is, however, where you have a bigger difference. This is the number of medications pre-op and post-op, and at 12 months, the number of medications is around about 0.3 medications or mean. And this, when you compare this with the number of meds in the Ahmed and barbell for the ABC trial, you can see that the number of medications is much more to attain the same pressure lowering effect that we showed earlier in the previous graph, somewhere between 1.5 to 2 medicines on the average for both the Ahmed and the barbell group. Erosions were 2.7%, which seems to be on the low side compared to the Ahmed and barbell literature. There was some endophthalmitis. There's some tube occlusion that was resolved by flushing the tube, and there were some shallow anterior chambers requiring viscoelastic injection. Again, nothing very different from the other implants. In the Singapore group, we have a 2-year follow-up, and if you can see here with 54 patients at 2 years, the pressure remains at around below 15, so somewhere between 10, 15, 13.8, and this is very similar to the international group at 1 year. Number of medicines at 2 years was also 0.36, which is again very similar to the international group that we showed you just now. So it seems that even at 2 years follow-up in this group of 54 patients, we are able to sustain pressure lowering and medication use very similar to the 1 year data. Of course, this is a new device, and we really don't have any comparison data versus the other devices in terms of a randomized comparison trial. And I think that needs to be done to validate further performance of this implant. It looks very promising, and the current use is certainly increasing amongst doctors who are familiar with tube implant surgery. This is the team that's been helping me to do it, and I couldn't do it with all these great guys behind me. Thank you very much for your attention.
Thank you, Paul, for a great innovation, and also thank you, EOI, for sponsoring this webinar. I would like now to introduce Professor Keith Barton, who actually don't need any further introduction, as he's well known in the MIGS community. He will be talking to us on decision making on which MIGS to choose for which patient. Keith?
Thank you very much for asking me to give this presentation, which is really on decision making MIGS case selection, both selection of patients and selection of devices. And I have a number of financial disclosures, which you can see. And obviously there are many new glaucoma procedures, of which those are some. The MIGS or minimally invasive sphere breaks down roughly into Schlemm's canal procedures, of which there are many, subconjunctival drainage procedures, suprachoroidal procedures, of which there's none commercially available at the moment, and some types of ciliary body ablation. As I mentioned, there are two questions really: which patient and which device? It might be appropriate to start off with consideration of in whom our MIGS device is completely inappropriate, and you have to use your common sense here. And obviously patients with uncontrolled advanced glaucoma who really need definitive pressure control with one procedure as quickly as possible and quite aggressively are probably inappropriate. These are the patients who we believe need target pressures of less than 12 and often less than 10, which is difficult to achieve at the best of times. And especially in a young patient, as young patients we have to be more aggressive. So we mustn't lose the opportunity to prevent vision loss by wasting time with a procedure that's insufficiently effective. The only real randomized clinical trial that looks at MIGS compared with conventional surgery, i.e. trabeculectomy, is the InFocus or PreserFlow microshunt FDA study INN005. And this shows that even the microshunt, which seems to be the most effective of the MIGS procedures around, lowers the pressure from 21 to roughly 14 millismercury compared with to 21 to 2 to 11 with the trab. So we still, even with the microshunt, which is the best, arguably the best or most effective in terms of pressure lowering MIGS there is, it doesn't seem to achieve quite as low as a trab. So I think in patients with very advanced glaucoma, we still have to be using the procedure that's most likely to control the pressure with one hit, and reserve MIGS for less advanced or less uncontrolled glaucoma. However, there are circumstances where MIGS might be appropriate in advanced glaucoma. And in general, if you have someone with advanced glaucoma who has a cataract, who is already very well controlled, then it's probably not unreasonable to offer MIGS procedure in order to perhaps reduce medication burden or prevent pressure spikes after the cataract surgery. But which MIGS should we use? Assuming, and I'm assuming in this talk that we're going to forward all of them and they're all available, which is obviously not the case in many places. We have the Schlemm's canal stent, such as the iStent and the Hydrus, which are eminently suitable in combination with cataract surgery. But there are a lot of different procedures in this space, the Schlemm's canal space. There are the stenting procedures, there are the cutting procedures. In general, the stenting procedures are elegant, minimally invasive, and we do have randomized clinical trial efficacy data. Cutting procedures are often less expensive, but there is more bleeding, they're more invasive and we still lack RCT efficacy. One might argue that these have similar efficacy because they're all doing the same thing, but the difference between leaving in a stent with not much cutting or not leaving in a stent with a lot more cutting may make a difference to the outcome, and this remains to be shown in trials. Then, of course, there's APGS, which dilates the Schlemm's canal, but again, we don't have RCT evidence. So at the minute, the only hard evidence we have is for the stenting procedures. And the evidence shows that they do leverage the benefit of cataract surgery. On their own, they don't seem to produce massive pressure reductions, but they do certainly produce better pressure reduction after cataract surgery than you would normally get. And I've included both the results of the initial Hydrus study and the G1 iStent study here, which shows the difference between phaco alone and phaco MIGS in terms of the proportion of patients achieving a 20% pressure drop. It's also worth pointing out that for the canal procedures in the US, you can only do them in combination with cataract surgery. If you don't do them with a cataract, you can't do them at all. That's not true in Europe. The contrast, the Zen's different. The Zen can be used either standalone or in conjunction with cataract surgery in the US. but the Schlems canal procedures cannot. In Europe, they're CE marked for everything. So the decision is more in the hands of the surgeon and the patient. So there are differences in licensing that's worth considering. What about subconjunctival MIGS? As I mentioned, in general, they produce greater IOP lowering than canal procedures, but they seem to be less effective than trabeculectomy. And like trabeculectomy, it is believed, although we don't have hard data on this, that they're less effective when combined with cataract surgery. And certainly Santen, the makers of the microshunt at present, I believe, are not recommending combining the microshunt with cataract surgery. The subconjunctival space, there's obviously the Zen and the microshunt. So there's two devices which are very similar, but have a slightly different approach. So if a patient is well controlled, needs cataract surgery, we should probably do a canal procedure rather than the subconjunctival MIGS. But if they're uncontrolled, probably the subconjunctival MIGS comes into its own, with the caveat that they don't seem to produce the pressure drop quite as much as trabeculectomy, so are perhaps not appropriate for the very advanced glaucoma. On the other hand, the subconjunctival MIGS are less invasive with quicker recovery, and patients will like this. And this again is, I'm repeating the earlier slide showing the showing the 1 year data after the INN-05 microshunt study, showing that you can get a pressure drop to around 14 mils mercury with a microshunt. Not quite as low as 11 with trabeculectomy, but it's still fairly impressive. One might point out that in this study, we used 0.2 milligrams per mil of mitomycin, whereas with microshunt implantation in general, we're now using 0.4, 0.5, which seems to give better pressure control. So this probably underestimates the effect of the microshunt, but it's still, trabeculectomy seems to win in terms of pure efficacy. This is a very speeded up video of the microshunt for those who have are not familiar with it. It's a fine polymer tube that drains aqueous to the subconjunctival space. Most of you are already familiar with the Zen, which is an ab interno approach. The microshunt is an ab externo approach, although the ab externo approach does look initially very similar to trabeculectomy, and you may think, well, this is not very minimally invasive. After you've done the mitomycin, really, from then on, it's nothing like a trabeculectomy. And you will see here that like a Zen, the key mark is 3 millimeters behind the limbus, except again, you're going in ab externo rather than ab interno. The 1 millimeter slit keratome and needle are provided in the package with the microshunt. And you've got to be quite careful not to distort the tissues. This looks very simple, and it is quite a simple technique, but there are a couple of tweaks to ensure that the microshunt doesn't sit on the iris or in the cornea. And it is self-retaining because the flanges are slightly wider than the width of the tunnel. Unlike the Zen, it's hydrophobic, and you do need to make sure it flows on the table before you close up. If you don't have flow visualized during surgery, then the microshunt won't work. And you've got to make sure it's not closed with it doesn't get blocked with tenons. The ab externo approach facilitates placement and makes it easier to avoid getting tenons in it. Whereas with the Zen, as you know, there's some postoperative manipulation to try and avoid tenons blocking it. And this produces a very diffuse posterior bleb because it's a longer tube. The bleb is starts 6 millimeters back from the limbus. So they are quite contact lens friendly as well. What we also need, as I've highlighted, is much better comparative data to give us a better idea of which procedures we should be using. Large data sets have taught us an enormous amount about cataract surgical outcomes. Glaucoma surgical practice is far more diverse than cataract surgery, yet no comparative outcomes are available across the spectrum of glaucoma surgical procedures. We've tried to remedy this with our International Glaucoma Surgery Registry, which provides the surgeon a free personal audit of their individual results versus a large data set. A data set of rough comparison of outcomes across all types of glaucoma surgery. It provides something that individual companies with new devices can use for regulatory purposes, and hopefully comparative patient-reported feedback across various types of glaucoma surgery. And this has been adopted by the European Glaucoma Society. And we currently have around, after 2 years, we have around 3,500 patients. So it's a relatively new database, and it gives you a very visual printout and audit report of your outcomes. And you can get a free login at either APGS.org/registry or simply IGSR.org. And thank you very much for your attention.
Hi, welcome back to the ISGS APGS webinar. I would like to apologize for the technical difficulty the last time we launched this webinar. Again, I would like to thank the members of the APGS and ISGS, especially to our speakers from overseas, from outside Asia Pacific, which is Professor Tarek Shaarawy, Professor Keith Barton, and also Professor Michael Coote. If you have seen the webinar, there is a question and answer button below. You can ask your questions to the respective speakers as we are all on live. And I would like to welcome all the speakers. We have with us, I mentioned earlier, the speakers from ISGS and from APGS. We have Dotan, Anthony Tumbocon from Dotan from Vietnam, Tony Tumbocon from Philippines, Paul Chiu from Singapore, and Prin from Thailand. And I would like to pass this time to my co-chair, Dr. Tanuj Dada, to start the live discussion. Tanuj?
Thank you, dear SK. So we have a lot of questions coming up from the audience. The first one is for Professor Michael Coote. So why not inject mitomycin C before you start revising the trabeculectomy rather than using a sponge? This is from Professor Augusto Blanco.
Thanks, Tanuj. Good question. There's two probably good reasons for it. One is that in a primary trabeculectomy, you don't expect to have any distribution problems for mitomycin C, which you do expect to have in a revision. There will be some partitioning. It will not go broadly where you expect. In fact, it might be quite difficult to get it where you expect. The second is that depending on where the failure has occurred, and of course the revision trabeculectomy is a kind of post-mortem, you need to find that spot and really isolate it and make sure that you have done something anatomic as well as added mitomycin to that area quite specifically, which I don't think you can do as easily with an injection. But it's a nice idea. I'm sure if it were a diffuse failure, that might not be such a terrible thing to do.
Thank you. So I would like the opinion of Professor Tarek Shaarawy. Tarek, when you do a trabeculectomy, have you switched to the injecting mitomycin C, or you're still using sponges? What are your views on this?
Tanuj, hi. First of all, hi.
Hello.
Hi from Switzerland. Look, this idea of injection just came in front of me a couple of months ago. It seems like I've been sleeping in a cave and came out and found that people are injecting. I don't know what this injecting is all about. I think injecting is not the appropriate way to apply mitomycin because you don't put enough time and you do not cover enough surface area. So I will actually discourage people from injecting. With one single caveat is when I'm doing a needle, I can inject a 0.1 milliliter of mitomycin because I'm not opening all the conjunctiva, but if I have opened the whole conjunctiva in a trabeculectomy or a deep sclerectomy and sometimes in a tube, why would I just inject and not give it the appropriate 3 minutes of a sponge at a large surface area? At least that's my take on the situation.
Thank you, Tarek. So the next question is also for Dr. Michael Coote from Dr. Zana, and that is, what is your time frame for doing a revision trabeculectomy? Does it make sense to revise it in 6 to 9 months?
It depends on clinical need, doesn't it? I mean, if you need an operation in the first place, you need it to work. So broadly, that depends on whether or not you can manage someone medically in that period of time. I don't think there's a minimum time, Tanuj, really. I think it's something that if the flap has failed more or less immediately, then the flap needs revision. It usually takes some time to create mature subconjunctival changes, at least 6 months really. And but I don't think it's required that you wait for that. So the only caveat is that I think that eyes start to become unhappy if you do too many things to them too quickly. So I think if you can restrain yourself for as long as possible, but it depends on clinical need.
Okay, thank you, Michael. So the next question is for Professor Tarek Shaarawy. So Tarek, what are your 3 key messages to prevent bad blebs after trabeculectomy?
First key message is know the conjunctiva very well before you start operating. Anticipate which conjunctivas are going to be difficult to handle intraoperatively and postoperatively. As I have shown in the video, I actually examined the conjunctiva prior to the operation and tried to move the conjunctiva with a cotton swab to give me some idea about how thin or how scarred it is before I do the operation, and subsequently choose the right operation. If you have a scarred, bad conjunctiva, even distally to the limbus, putting a big tube there with a big profile might result in catastrophe. So first key message, know the conjunctiva. Second key message, understand what kind of operation would be applicable to this conjunctiva, and then use mitomycin, but use it in a clever way and distribute it over a large surface area. You do not want to keep it in one specific place and finish with a localized high bleb that are those blebs are not just a precursor for endophthalmitis and blebitis, but those blebs are also very uncomfortable for the patient, and do not underestimate the effect of bad blebs on the comfort level and the quality of life of your patients.
Thank you, Tarek.
Sorry, Tanuj, I think there's one question to Tarek regarding this. He's asked, the question is, Tarek, if you hydrate the conjunctiva, wouldn't it make the surgery difficult by hydrating?
No, yeah, I mean, the question is related to the first step that I do in glaucoma surgery, which is basically to do a hydrodissection under the conjunctiva. In my hands, this is a step that is extremely important because it gives you an idea about what are you dealing with in terms of conjunctiva. And the trick is, if you are injecting between the tenon and the conjunctiva, you are creating an edematous area, let's say. But the trick is to make sure that you are injecting subtenon, under the tenon. In that case, you are lifting both the tenon and the conjunctiva, and it will not make the operation difficult. In fact, it kind of does a sort of a gentle dissection even before you go in with your scissors.
Thank you. Back to you, Tanuj.
Yeah. So the next question is for Dr. Do Tan. So for pseudophakic eyes with malignant glaucoma, wouldn't it be better to have a corneal approach for the iridotomy, tonsillectomy, vitrectomy rather than the pars-plana approach?
Yeah, thank you for the question. So my preferred approach still the pars-plana vitrectomy, because if you want to create the communicating pathway into eye I think that we should to do the anterior vitrectomy completely, because if you take the corneal pathway, you do the creating the communicating pathway from anteriorly to posteriorly, you cannot make sure that that will be blocked in the future by the vitreous.
Okay. And supposing you have done one eye and the fellow eye is also going into malignant glaucoma after you're doing surgery, then would you recommend long-term atropine therapy, and for how long?
I have some cases that can be treated successfully with the atropine for a long time, and that the case that I used atropine for 10 years. And firstly, I gave her atropine once daily, and after that I extended the interval between the doses of atropine. So now he's still using atropine once a week, and it's still working very well.
Thank you, Dotan. The next question is for Prin. So when you plan for a controlled hypotony for a long-term success of filtering surgery, what is the level of intraocular pressure you would like to maintain to prevent glaucoma progression?
I think, frankly speaking, we don't know. We know that we have to get the pressure as low as possible. And there's interrelated factors that we have no control, like the CSF pressure is another thing, the balance between the laminar fibrosa between the two sides of. So basically, it depends on what was the level of IOP that make the nerve damage. What was the level of IOP that you saw, you identify progression, and then you have to go lower than that. Control hypotony is, frankly speaking, it's get it low and it's slowly creeping up because of the wound healing, and the time.
Thank you, Prin. The next question is for Tony, and that is, when you're implanting tubes in eyes with previous encerclage, do you implant the drainage device behind the scleral band or over it? And
that's a good. Yeah. Go ahead, Tanuj.
One more question. Yes, hello, Tony. And there's one more question for you. When you do tubes in Asian eyes which have a shallower anterior chamber, would you recommend doing tubes in pseudophakic eye and having a ciliary sulcus implantation preferred over anterior chamber implantation?
Very good questions. With regards to the encircling band, if there's an encircling band, usually it's placed 8 to 10 millimeters. So I just place it right on top of it. Whether it's an AMED or Barvelt, it gives, just as long as you dissect properly, you use the plane of the capsule of the encircling band and dissect laterally all the way to the recti muscles, and you'll be able to place either a Barvelt or an AMED. The AMED's a little bit thicker, so sometimes it could be a little bit tricky, especially if there's a sponge there, or if there's there's another device in that area. So it becomes a little bit tricky. But in general, it's still 8 to 10 millimeters posteriorly. With regards to Asian eyes, whether I prefer inserting it through the ciliary sulcus, yes, if the chamber's a little bit, if it's already the eye's already pseudophakic, then I would prefer to put it in the ciliary sulcus, especially if there's corneal compromise or after penetrating keratoplasty, just like what I showed in the surgical videos earlier. And of course, there's also some other instances. You just have to make sure that the iris doesn't get trapped. And you could do that by doing bevel down position and place it right on the IOL. Just make sure it doesn't tilt so much.
Thank you, Tony. The next question is for Dr. Paul Chu. Can you comment on the hypertensive phase after the POG glaucoma implant? Is it similar to other drainage devices?
Thanks, Tanuj. The hypertensive phase is, I think, relatively mild if you have the immediate immediate flow. Usually, there isn't as intense a hypertensive phase. I think it's a combination of the plate size is quite large and the extension is quite posterior. But primarily, I think it depends on the technique. As long as you're having flow initially, the hypertensive phase is mild. It's managed much the same way in the sense that I guess a combination of appropriate anti-inflammatories and some aqueous suppression is all that's needed for a few months.
Thank you, Paul. The next question we have for Dr. Keith Barton. If you're doing a cataract in a patient who has had a trabeculectomy with advanced glaucoma with an IOP of 10 millimeters of mercury, would you consider implanting an MIGS device like iStent at the same time?
No. I think that just answers it. Yeah, I think if your trabeculectomy is working well and you've got advanced glaucoma, then in general, I do nothing. I usually give a mitomycin injection to try and preserve the trab. If the trabs have got more borderline success, in other words, advanced glaucoma and the pressure's 15, then I would needle at the same time. But doing a separate procedure just has no logic at all from my point of view.
Okay. There's one more question for you, Keith, that is regarding the decision making on which MIGS to choose for which patient. And the doctor has asked, is there any case where you would choose the Zen implant instead of the pressure flow?
There's, I think at the minute when we compare Zen with pressure flow, we don't compare like with like, because the Zen, if we implanted the Zen ab externo, I would love to see any data, but it's probably very, very similar in terms of success to the pressure flow. Whereas the Zen ab internal, as we know, has a lot of bleb management problems that you don't get with pressure flow. So if you're going to do Zen ab internal, in general, I would prefer the pressure flow. But I must say, if someone came to me, did a lot of ab external Zens and said they were getting the same results, I would believe them probably. The only difference is the Zen being a little bit shorter. It doesn't drain quite so posteriorly. But when you go ab external, you avoid all the problems with injecting mito, for instance. We had a conversation about injecting mito earlier, and yeah, I don't inject mito. When I started doing Zens, I did it initially with trabs and then realized that the bleb morphology was terrible because you have no control over where the mito goes. And that's part of the problem with ab internal Zens. Ab external, you can place the mito with sponges and you can get much more control over where it goes and control over bleb morphology. So ab external Zen versus ab external pressure flow might well be exactly the same. I don't know.
And Keith, would you recommend using the MIGS devices as standalone devices? Would they give a better outcome as compared to combining them with phacoemulsification?
This is a difficult one. The reason they're so popular combined with phaco is because you're going to the operating theater anyway, and they're easy to put in. They're not quite convincing. I'm talking here about the canal procedures. The canal procedures don't have enough efficacy for us to go in standalone. And in the United States, they're not even licensed as standalone. If you don't put them in the United States with cataract surgery, you don't put them in at all. So you have only one option to put them in. Ab external MIGS, subconjunctival MIGS are a different animal, and they seem to be less effective in combination with cataract surgery. Like trab is less effective in combination with cataract surgery, and even Barvolts, as Eamon Shaarawy showed, seem to be a little bit less effective in combination with cataract surgery. So every kind of subconjunctival drainage you do seems to work a little bit better if you don't combine it with cataract surgery.
Thank you. So there's a lot of talk about primary tubes. So I would like the opinion of Tarek and Paul Chu. Is there any situation where you recommend primary tubes, or you would go ahead with a trabeculectomy as a standard procedure for a primary open angle glaucoma?
Tarek, you first. You're muted, Tarek.
Here you go. Primary tubes are something that I do quite rarely. I've been influenced, I have to say, by the work of Andy Christian in Canada, Andy speaks a lot about primary tubes for people coming from far areas and elderly patients that are not going to withstand multiple revisions or things that you have to do post-operatively. And that probably is my sole indications, patients where I think I want to give them a easier post-operative profile or period compared to after trabeculectomy or deep sclerectomy. Very elderly patient, handicapped patients, and in some cases I would put a primary tube in uveitic glaucomas, but that is not a standard procedure. My standard for uveitic glaucomas would still be a deep sclerectomy if the angle is open.
Thank you, Tarek. Paul, final comments from you?
Yeah, I have my conch is very inflamed from, let's say maximal drug therapy, or there's a lot of blepharitis. I'd consider a primary tube in our population. I think conch health and conch inflammation may make our crabs do rather poorly. So that may be another reason, following what Tarek said.
Thank you, Paul. So I think we are now run out of time. I just want to thank all the fabulous speakers and my co-host, Dr. S.K. Fang. This was one of the best surgical webinars we had with the top surgeons across the globe. I also thank the audience for a very active participation, and we hope to hold further collaborative webinars between APGS and ISGS. So with this, I would like to thank all the speakers, chairs, and the audience, and just mark your dates. The Asia Pacific Glaucoma Society will be launching its master class, and the first one is by the president, Dr. Keith Barton, on how to use the OCT in your clinical practice today and beyond. So mark your calendars, and thank you once again for your participation. Goodbye and have a safe day. Thank you.
Bye-bye.
Bye.